I am thrilled to welcome our keynote panel, who will be moderated today by AC, the Associate Professor of Operations and Associate Director for the Center of Operational Excellence at Ohio State University. Please put your hands together for AC and this morning's panelists.
Thank you. Good morning, everyone. So again, my name is Aravind Chandrasekaran. I was just telling her you can call me AC. My last name is a tongue twister, so I just go by AC at Ohio State. And I'm really delighted to be here with you all with this exciting panel. Our topic for today's panel is about this whole idea of digital era, big data, and technology. Before we go there, I really want to spend about 1 minute, 2 to 3 minutes about what you all are doing and how important your role is in the delivery of care. So as a slight background, I'm a researcher. So I come from the business school, but a lot of my research is in the area of healthcare delivery. So I try to understand how do organizations structure their process outcomes, and how are those, when you go and change something in an organization, how is that change actually affecting outcomes? In a healthcare context, how is it affecting patient outcomes? And in my world, I view patient experience a bit broadly. So I don't really look at HCAHPS alone as patient experience. I'm sorry. Technology is bad. I apologize. So I don't view patient experience as just HCAHPS alone. We look at more long-term outcomes of patient experience in terms of like anxiety levels of patients, their 30, 60, 90-day readmissions. So I want to show you something which actually is a good start on an early morning on why you are all important in the context of healthcare delivery. And here is one thing. So one of the things that I want to show you is we did, and by the way, all these research studies are all published in peer-reviewed journals. And I'll be glad, again, it's all available on my website, and I'll be glad to send you some copies of this if necessary. One of the cool things that I found is that I had a doctoral student who's now a professor at University of South Carolina, and his entire dissertation was looking at this concept of Office of Patient Experience and the role of Chief Experience Officers, which you are all here in this, and try to understand, okay, how are they doing things differently? Are they really actually affecting bottom line? And the way Love did his research is not just like correlation analysis. He actually had a quasi-control group where he looked at hospitals that didn't have this and tried to understand pre and post outcomes because of this office. So the encouraging sign here for all the wonderful things that you do is actually that having an Office of Patient Experience, which is, again, an independent entity which directly reports to the CMO and has its own budgets. It's different than the quality and patient safety. What he found was that it improves communication. So he was able to go and measure more fine-grained details about communication that happens in the hospital between providers and patients, not just relying on HCAHPS scores. And he found that that actually improves communication. He also found that that improves long-term outcomes such as readmissions. In fact, there is a Harvard Business Review article that I wrote on this, and you can go and read about it. It's all about the roles that you all do, where it actually affects your role as enablers of patient experience in your hospitals, actually not only affects HCAHPS or patient experience, but also affects readmissions, long-term readmissions, after accounting for a lot of patient characteristics. What is the catch? This is something that I really think we should all understand, is that it's going to have some initial cost. There is going to be some initial cost that your hospitals have to incur. And what is encouraging about that is actually that cost comes down over time. So we were able to show in this study that there is going to be some increased operating cost, and we were able to even identify why that operating cost goes up. But then over time, we found that the hospitals actually reduced in the operating costs. So the real thing that I want to tell you is that what you are doing in your own organizations is very important, because it's actually affecting patient outcomes, not just patient experience, but a lot of patient outcomes too. One more thing I want to tell you about. So, okay, what are some real good drivers of this patient experience? Given that we've had a lot of good discussions on what drives and what doesn't drive. And here are a couple of studies that we actually did in collaboration with, I'm from Ohio State, so we did some work at the Wexner Medical Center, which is a very large teaching hospital. and I have also done some work with the Mayo Clinic in Minnesota and Wisconsin. What we found is that, keep in mind that the two important drivers of patient experience, after we account for a lot of important characteristics, is that it all comes back to this empathy. I heard a lot of yesterday's discussion on this idea of empathetic care. That keeps coming. When we actually measure what really drives patients to actually well-being, not just HCAHPS scores, we find that empathetic care that is delivered in the front line becomes a very important predictor of how patients actually are behaving after their care has been delivered. We also find consistently that adherence to standards of care becomes a very important metric. So if you were to look at those two things alone and measure them in your organizations, you could confidently say the better you do on them, the better you're actually enabling patient-centric and patient experience care. The last thing I want to say on that is, okay, what is one thing that you all can do when you go back and actually try to understand this whole enablers is the psychological safety among your teams. So, and again, this is not just me. There are lots of other researchers. In fact, this concept of psychological safety was developed by a professor in Harvard Business School named Amy Edmondson. And she studied this for about 30 years in care teams, especially nursing teams. She found that psychological safety, the way you actually empower your frontline, the way they're able to make decisions, the way they're able to execute, the way they're able to fail and learn from those failures, all those characteristics, the more stronger the psychological safety of your frontline staffs are, the more better your care delivery outcomes are. And this, again, is not something new, but in our studies, we find that there is a very clear causal link, because a lot of our studies have randomized control. So we actually have half of our interventions given to some teams and half not. And as we measure some of these things pre and post, we find that is an important predictor. So I leave that with this and say that what you're all doing is very, very important in the concept of patient experience and patient journey. And if you were to go back and reflect on some of the things that we've been learning in the couple of days here, think about some of these things. To say, okay, if I want to use technology, if I want to use some of these things that we discussed, how am I going to actually improve some of the frontline performance, and how is that going to affect patient outcomes? So with that introduction, I really want to introduce the panel today, because when I was having breakfast here, I learned a lot about some of the great things that they're actually doing in their organization. So why don't we actually start off by having them introduce themselves. I told them also to talk about what is their role in their organization and what really excites them as they are actually thinking about this work on patient experience.
Hi, good morning. My name is Liz Paskas. I'm not sure if it's day, night, evening. I'm a little, so I apologize for any confusion, but I am the Vice President of Experience Innovation and Consumer Services in the Office of Human Experience. And we don't necessarily call it or focus on patient experience for a lot of the same reasons that you shared. I'm a nurse by background, critical care, cardiac surgery, and trauma nursing. Those things still excite me. I'm an adrenaline junkie, even though you might not be able to tell that now. And what excites me is if I can actually keep my room till 5:30 so I can get some sleep. That's my priority right now. My psychological state is not quite there.
You're doing well. Good morning, everyone. Alan Dubovsky. I'm the Chief Patient Experience Officer at Cedars-Sinai in Los Angeles, California. I have been at Cedars about 18 months now. Prior to that, was with Emory Healthcare in Atlanta for about 10 years, and have been doing patient experience, patient satisfaction, everything in between for about 17 years now. It was actually my very first job. Two really important things. The one thing that excites me is I'm looking at my photo, and I think to get it to the same size, you have to make me so thin that I look incredibly good in my photo this morning. So this is the one I'm going to use from now on. It's like a slimmed down version of me. I think the other thing, and why I'm really interested in this conference and the panel, is as the first chief experience officer for a pretty large academic health system, this is really fun for me, right? The idea of sort of marrying up the world of true sort of human interaction and everything we need to do every day for us, the 900 patients we have in-house, with what's out there in terms of innovation and technology, and how do you truly map the data and the new technology that's available to prove that patient experience is important. And so in the 18 months I've been at Cedars, I'm happy to share as we go through the panel, we've done some really cool work around how this isn't just sort of the office of fluff, as I think we've all struggled with a little bit, and the data actually shows, to your point, AC, from the introduction, how much this actually affects all of the downstream operations and everything else across the health system. So thanks.
Hi, I'm Julie Becker. I'm the Chief Experience Officer for Regional Care, or RCCH Healthcare Partners. It's a mouthful and hard for me to say. And I agree with him on the pictures because I do not look like that on the one on my site when you go to. My head is huge. So I appreciate that I look smaller in that picture as well. The other thing that I thought was interesting was the discussion around the Office of the Chief Experience. Do I count if I'm just one person for all of the 16 hospitals? Because that's where we're starting. This company got together about 2 years ago. Regional Care had some hospitals, and Capella Health had some hospitals, and they joined for this new company. We are based out of Nashville, Tennessee, and we do not have any hospitals in Tennessee. We have them spread out over 12 states, and none of them are really that close to each other. So it's a unique opportunity. They're community hospitals, and so we're going into communities and helping these smaller hospitals come together and get support that they need to stay sustainable. But the other thing about working with local communities is they often can't get the services they need. So we want to be able to provide services that they need, but we know that we can't bring people to the communities like we might in the larger cities. So we are going to be looking towards using technology to help us get what we really need for these local communities. I'm a nurse by background as well, and I've been doing this for many years. I just came from an academic center at the University of Wisconsin, where I joke that it took me 6 months to get anything approved. And here they just say, go do what you need to do and tell us how it goes. So vast difference in what I'm able to do now, and it's very exciting to me. So I definitely like going to work.
Great. Good morning. I'm on the other end of the spectrum. I come from the private sector where you could do whatever you wanted to do, and now it takes a while to get approvals. My name is Vishal Bala. I'm with Parkland Health and Hospital System in Dallas. Been in healthcare about 2 years. I come from the hospitality background. I was blessed enough to be able to realize I wanted to serve in healthcare and take a break to educate myself to be able to do the transition. In terms of adrenaline junkie, I'm a data junkie. Also, we at different panels we talked about, are we measuring the right metrics for patient experience and so on and so forth. I'd love to talk about that later on. We at Parkland, this is the second attempt at patient experience and employee experience. I was lucky enough to be able to sell the concept of ensuring we have employee experience first. So I just handled employee experience for 6 months, then added on the patient experience piece, and now we're working on physician experience. In the last 6 months, we've been able to demonstrate some great wins. Hopefully they sustain. It's not a flash in the pan. But in 6 months, we were able to move our patient experience scores in a decent manner. And also, first, before that is the employee experience. And how many here feel that you have some control over your employee experience when you're taking care of patient experience? Just an idea. I wanted to see how many. So there's a fair amount. Great. So what we did, I'll just tell a small story, because I think the topic is big data. And sometimes, with so many metrics, when I first walked into Parkland and I shadow on the floor every second week, on the units we had 18 metrics that the unit managers were looking at. And out of the 18 metrics, 14 of them would change every so often, and the patient experience metrics changed every quarter. And they were action planning around that. There's a story about the Second World War. When the planes were coming back for the Allied forces, they had statisticians look at where the bullet holes were, and they wanted to armor plate the plane in those areas because you couldn't armor plate the entire aircraft, would make it too heavy. And they did their statistical analysis, and before they started armor plating, one of the statisticians, who's my hero, said, hey, how come there are no planes that you've shown that there are bullet holes in the engine? Because those planes never made it back. So the big thing about data is not just to see what's there, but to contextualize it. And sometimes we get lost in data. The idea is to simplify it and make sure everybody understands what we're working towards and then align towards it, which is what we have done. And most people join healthcare because they have a passion to serve in it. And all we did was remove the clutter from their table, demystify a little stuff, and enable them. So thank you.
Oh, great. Actually, that's a good segue to our discussion, because one of the things that we all struggle with, it doesn't matter whether it's small data or big data, we are now compounded with like big chunks of data. And how do you actually differentiate between what is good data and what is noise? Because a lot of times you get into this thing of, okay, I have so many variables, so many things to understand, but I really want to understand what are some variables or some things that predict the real patient experience. So go back to your conversation, Vishal. So tell us more about how your hospital actually uses some of the big data to identify what are some important predictors, and how do you filter the noise from that big data?
So I think first, based on our mission and values, and what the organization is shooting for. We're a nonprofit. We don't turn anyone away, so profit is not the primary objective. So we made sure that the board and the chiefs were aligned on what is the, from whether you want to call it press Gini or age caps, or what is it that we're working towards. Pick one item. Is it overall score or likelihood to recommend, or what is it? So they picked likelihood to recommend. Great. Now that's not actionable. Right? It's a dependent variable. So I always give this example. If you try to skip stones in the pond, well, mine always just goes down. It doesn't skip. But there are ripples, right? So if you work on the ripples closer to the center, those are independent variables, and the ripples on the outside are dependent on the ones closer to the center, right? So if you look at your questions, whether it's employee engagement or patient engagement, you look at what are the independent variables. And they're easy to identify because that is something you can action. It's more tangible. My nurse treats me with courtesy and respect, right? My provider treats me with courtesy and respect. Responsiveness to the call bell, right? So these are the three actually we picked. So what we did was we ran a quick regression analysis, and you can always have a statistician come and do it for you in 15, 20 minutes. We took the likelihood to recommend, and we said for Parkland, what are the three? And I keep it down to three, because to focus on more than three is a little difficult. What are the three independent variables which are most correlated for us to likelihood to recommend? And these were the three. And then we look at best practices around these three. And we have a cross-functional team of people on the front line, and also up to the chiefs, working on how do we take those best practices and apply them to Parkland. And they're coming up with that, and we're making them clinical competencies and rolling them out. Okay. But we haven't rolled, the interesting piece is we started this journey in November. And the score was supposed to be 89.3, and our vendor told us it'll take us 2 years to get there. That's not wood, touch wood. In March and April, we hit 89.3, likelihood to recommend. And it was only because not that we rolled anything out, but the teams were engaged, and everyone knew this is what we're focused on. Forget about everything else, right? And just that has got a lot of momentum.
Right. Others, how do you use data to actually make informed decisions on patient experience in your organizations?
I think for me it was, it's been kind of right-setting things since they're new coming together. And there's great variation between what they were doing with the patient experience at each site. So we had to look at all of the data, and they were bouncing all over the charts in terms of what they were focusing on. So 1 month it would be this, and then they'd look at a score, and then they'd jump over to some, because they had nobody guiding them in terms of how to look at the data. So I agree completely that there was too much, and you can't do 12 things. And so let's really look at that priority analysis for your site. And as I started working with all the 16 sites, it worked well for me in that we all had similar issues. So I was able to do something across the organization around the nursing domain, because in our inpatient setting, that was killing us. And so we were able to bring together a group of the CNOs from all of the sites, and we have a work group, and we've been working on best practice around that, that domain on the HCAP scores. And they were grateful to be able, first of all, to talk to each other because they're very isolated and say that they don't have networking opportunities like they would like to have, but also to talk about what the data meant because they all had different ideas about what it meant and what they're supposed to do to improve a certain domain. And so we were able to distill it down to a point where they could work on one thing and focus. And I think the lack of focus was wearing them out. And it was frustrating the senior leaders who didn't understand what was going on. And so luckily we can now have a strategy for the whole organization around best practice for this domain and go from there. And the next one will be working with the physicians. What are we finding about the physicians across our organization? And again, it's interesting that we're finding similar problems with those questions as well. So I am a simplifier. That's what I like about my job is UW had 97 questions on their inpatient survey. 97. First of all, not many people knew that. And secondly, I said, I want whoever's using these questions needs to let me know what they're doing. And I think we found out of all of those 97 questions, maybe 10 were being utilized. So why are we asking our patients 97 questions? So when I left there, I swore I was never going to do that again. And I have been distilling surveys and distilling surveys and distilling surveys. And when we get to the 80th percentile, and we will, then we can add some more questions because we'll need some more data, right? But until then, we have enough information. Patients are telling us enough in real time as we go out and get other data, not just survey data. They're telling us what they need every day. And we just need to start listening to that and simplifying, simplifying, simplifying.
Good point.
Yeah, so I'm going to come back to predictive analytics, which I think we'll talk about in a second, which is sort of the future of what we're doing with all this data. In yesterday's meeting, in a couple of other forums that I'm part of with people in this room, we've talked a lot about the surveys and the feedback and the design and everything. There's no doubt that we're all in this survey fatigue, right? So our patients are, we've been using HCAPs for forever. We were at 88 questions. We're down to sort of the required ones. For me, it's been a complete shift over the last year, and I'm very lucky to work with NRC and other great vendors to be able to figure out what we really need to understand from our patients that doesn't follow some sort of government-mandated survey. I appreciate the need to do all of that. And so truly the shift for us has been how we start using our comments. Because for me, that's honestly where we're getting the very candid feedback from our patients. And it's a really interesting thing, and I'll give credit to Alpa from Stanford, who said this yesterday. It's even funny to me that those are at the end of surveys. To me, those are the most important questions. So literally, it's like, hey, what do you want to tell us about your experience? And then if you have a few minutes, we'd love to get your feedback on everything else. So we went... we redesigned our surveys, we went to real time, all really good moves, but we went from probably 10,000 completed surveys a year to about 160,000 across our health system. And so that presented a whole new problem. What do you do with that? And so now using really sophisticated tools to be able to mine out of the comments, specifically the 50,000 comments a year that we get, what are the themes, what are the trends at an individual level, at a practitioner level, at a practice level, has really been for us the massive shift. So we don't actually talk very much about the data points anymore. We talk significantly about comments. It's where I spend my time with our physicians around coaching, bedside nurses, et cetera. That has been, it's got people re-excited and reinvigorated in like, okay, like now I can see the patient experience from a different perspective versus chasing down some sort of, random question about, took my preferences into account, which doesn't really help you figure out what to do.
Good point. Liz?
So a lot of what was said, and I'll go back to Vishal's point because we too were looking at regression analysis, and we also had the opportunity to switch vendors and partner with NRC in order to be able to obtain this qualitative feedback, which I agree with Alan. It definitely changes how you look at your what the patients are saying, and when you look at it from a domains and the actual questions to what are they telling us is important to them. And one of the tools that NRC has is this priority matrix that tells us, what's the top priority and the high priority and how highly correlated are they to driving the patient experience. We then take that information and then look at those segments in the real-time feedback and then break that down even further doing the qualitative analysis to say what specifically are the top things that each of the hospitals can work on in order to create an always experience. But then how we take that another step further is we're very fortunate to have a business intelligence division who interfaces with almost every platform that we have, and they drive all of that information into what we call the human experience dashboard. And in that dashboard, we have the patient experience data, qualitative, all that. But we also have our patient team member engagement scores. We look at turnover. So it's kind of looking at all of these different data points and saying, you know, specifically for a hospital or a unit, what are the things that are influencing and impacting the inability for them to deliver the care that they want to give. And through having that information, one of the things that became very clear to us is that we need to focus, and we are the Office of Human Experience, meaning that we're also focused on the team members, the doctors, and the folks that are delivering care. But more specifically, we need to focus on them first, because if we do not do that, we're not going to get the other things that we're looking for. We then also tie that to quality, safety, you know, the units that are having the most events, the patient grievances, you know, and it's so you can walk into a unit and you can say, okay, here are the top 3-4 things that they need to work on, because it's impacting all of those different metrics. So we're excited because our partnership with NRC started in January, and in the first quarter, we had over 50,000 surveys completed. So that's a lot of information. So to be able to narrow that down in a BI tool, it makes it easy for us to use the information that we're getting.
A couple of things are actually surfacing out from this discussion. One thing is, given that you have big data, again, you're all familiar with this whole idea of Pareto principles, right? So going to the vital few and understanding how those vital few actually affects the outcomes is more important. And I think you could use good statistical analysis. But one thing I'm hearing this, and I'll tell you my story on this, is actually I did a study where we were trying to minimize readmissions for kidney transplant recipients. And this was, anybody here working with the transplant team would realize that the readmission rates for a kidney transplant recipients were about 35%. This is the American Kidney Foundation telling you. And then if you were to break it down into how many of those readmissions are preventable, that's actually half of that. So half of that readmissions are preventable because people are not complying to discharge instructions. So in this study, what we did was we looked at, okay, how is the discharge instructions delivered? And we found that they were delivering 80 different instructions in 4 days. And 80 different instructions being cramped into 4 days because they had to deliver. Nobody did anything about any analysis or any data to say, okay, what of those instructions matter? So what happened was actually they developed an intervention where the frontline team who was developing, which was all the nurses and the transplant nephrologists, said, I'm going to look closely at those instructions. And I'm going to see what are those instructions that affects the patient outcome. And one caveat here is they really didn't care about HCAPs. They said, screw with HCAPs. I don't really worry about HCAPs. I don't buy HCAPs. So we pushed them hard and said, okay, what do you worry about? They said, I worry about patient anxiety. So I measured patient anxiety at the time of admission and at the time of discharge. And I want to understand what affects patient anxiety. And they started looking at that measure, and those 80 became 30. And 30 became more standardized, 30 became more personal, and then what they found was the anxiety levels lowered. At the end of the day, HCAPs also improved. So at the end, one of the important things that I see is like, don't worry about final outcomes, but worry about process outcomes that matters to you more.
So great segue and great point from you as well, Liz. So remember I talked about contextualization with that plane, and what we do with the data, I think, is to focus in on what we need to focus in on, and then add the people piece, the comments, the staff. So we talked about journey mapping in 2 of the sessions yesterday. Now, we're also journey mapping our employees, not just the patients. Sure. On the floor, not just from recruitment to when they leave the organization, but on the floor. And in transparency, when a patient passes away on the floor, what do we do? How do we take care of that team member who was empathetic to this patient for 2 months? right? What are we as an organization doing? And then how do you expect this employee to now, this team member, this human being, to go and serve someone else with the same pep in the step, right? I think that's the key. And then identifying, so we use the data to zoom in on what we focus in on, and then we have to contextualize. And the only way we can contextualize and get the buy-in from the team, absolutely, get the leaders involved, but also get the front line involved in building the solution. And once they build the solution, then together, as leaders, we make sure they're resourced, and then we put accountabilities and metrics. So then now metrics are, forget everything else, this is all we're measuring, and everyone knows why we're measuring, and the team members help build that.
Sorry, and this might be a little bit of a segue, but to your point and then your introduction around the Office of Patient Experience, so every job I've ever had, I've sort of replaced somebody. This has been my first one where I've been able to come in and sort of design this Office of Patient Experience. And the first question the COO had for me is, like, who are the types of people that you want on your team? I'm assuming what you want to go hire is, trainers and sort of project managers and all those things. And it's been really interesting for me that two roles that I feel are most important, again, for me at this point. One is somebody who can understand the data, and I think what we've done really badly over the course of time is we've hired a lot of people, or we work with a lot of people who just report the data. Sort of true statisticians or people who understand it or people who can mine the insights out of it are worth their weight in gold, and I think that having somebody like that on your team is critical. The second would be somebody who's really good at that concept of journey mapping, human-centered design, whatever you think about. I think we've all talked a little bit about that. It's, once you've got the insights out of that, how do you then go back and figure out that process of what either the patient or the employee goes through and lay that over? Around the rest of the organization, you can find people who can help you implement projects and manage it, but for me, those are two critical pieces, and I think that's why the data becomes more manageable as opposed to just looking at mass amounts of it.
Good point. So let's actually switch gears and talk about the dark side of data. Because yesterday I was looking and I was hearing this word creepy, actually. I think there are some challenges when you're dealing with data. So I want to hear your thoughts on it. Again, do you see any challenges as you're looking at these data? And if so, how do you mitigate those challenges?
I think for me, because we're in smaller communities, I'm getting a lot of pushback around what they think their population wants or does not want. And so they're implying a lot of things that I don't know that are true, right? For instance, my parents have not been married for a long, long time, but my dad loves technology. He's 78 years old. He has more stuff than I have. And he can teach me things I don't know, but my mom doesn't even own a computer. So for me to say that that whole age group doesn't want technology to help them with their healthcare is not accurate. So I think my struggle right now is really figuring out in the communities, what do they need in each community? And I'm finding that it's different. So I can't globally say, I'm gonna bring in a company and we're going to blanket all of these sites with this certain type of technology. So I'm very drawn to types of technology that are flexible, that maybe standardize, yet let us have flexibility to customize. Because I need to go out in all of those communities and really evaluate what is it that they need, what will they use, and what will be of benefit to them to improve the outcomes in those organizations. So for me, it's very simple. I have to go out and do assessments and evaluations and figure out what they each need. It was easier when I was at one site and we could do something, but this has been really interesting to me as well because it's challenging me to be more creative in ways that I would have never thought of doing when I was in one building and one site. And so I also think there's opportunities for us to decide how we're going to deliver care in these more rural areas than we are now. So that's the exciting piece to me, also the challenging piece to me. Right now we are rolling something out with rounding. Somebody talked about Cypher Health yesterday. And so we have a rounding tool and we have an automated callback system that I'm very interested to see how that works. So when they first said automated to me as technology, I went, oh no, we need people to talk to people. We can't lose that human side. But at the end of the day, we needed a human to make those phone calls, right? And so that FTE was not guaranteed. That was somebody who, if you had time, you make these phone calls to the patients. And I found consistently people didn't have time, right? So the phone calls were not being made. With this automated system, if we have a phone number, we can make those phone calls. And not only can we make phone calls, we can gear it towards what we need to gear it for and triage it appropriately. So I'm very excited to see how that works. And we are rolling that out across the organization because we can, but not all technology can do that. So I think that's the challenge for me.
I would say that the challenge, going back to what Alan said, is historically folks were putting out reports on the experience, and sometimes they were trended reports, and they would say that, well, this is because we did this or because we did that, and there was no true story around what the data was saying. And so Hackensack Meridian Health is a new, I would say still new merger, because we're going into our second year in July. And so there's a lot of education that we've been doing. We've been changing a lot of things. And one of the things that we did is the Office of Human Experience is new, and we changed the way that they look at data. So the challenge for me, I find, is getting mostly the hospital presidents to believe the information that we're giving to them, because we're not giving it to them in a report with red, yellow, and green. We're saying, here's what your data is saying, and this is what you need to do. And a lot of times they're challenging that. And I love the challenge because it helps me to sort of dig deeper with them and then monitor other things to say, well, if you don't change this, you're not going to change your outcome. But I think getting folks to believe the new way of looking at things has been the challenge in our organization. Now that's basic because some people may be very far ahead, but I share because as you look at data differently, and we have, like I said, the Oracle BI dashboard, but a lot of what's in there is, although there are some correlational studies, and there is some predictive analysis, there's no story in there. You have to sort of pull that out and give that to them in a different way that's tangible for them. And that's been the struggle. I think we're getting there. They have my cell number and they text me, and they'll say, I get it, that's awesome, Liz. And then they'll say, you know what, I don't really believe this. So they're still sort of struggling with it, but that's my challenge.
We talked a little bit about this predictive analytics. I'll talk about a project just very briefly and then the sort of creepy side of that. So again, we're sitting on probably 180,000 pieces of feedback, and how do you bring all of that together, and how do you use it in a way that sort of makes an impact every day for the thousands of people that come through our system? And so the frustrating thing to patients is they keep telling us the same things over and over, and we don't really do much with it. And so the idea of predictive analytics is really interesting. How do you take all these things you know about patients and try your best to guess what is going to happen to them while they're there? So we put in, I think we're up to about 300 different variables into the system. Simple things, new versus return patients, demographic information, socioeconomic. We fed in all the patient experience data. We fed in clinical outcomes. And so we've got this whole long list of things, and what we're able to identify is, in all likelihood, out of the 900 patients in-house today, like here are the ones that you should probably be rounding on, and here are the things that you should probably talk to them. This patient is very likely to need more information around discharge. This patient is probably going to give you a 10 out of 10, and so if you have to pick between the two, maybe your time is better spent on that one. It's wonderful. It really actually does work. The confidence levels are pretty high, except when they aren't, right? So I guess sort of the creepy side of this is it's not perfect, and what you might land up doing is a couple of things. One, you could freak people out entirely. So that works really well when I think you've got professionals who can come in and have that conversation. Not that we would have people do this, but you could have people go into the room and be like, listen, I just wanted to check on you because based on my data, you look like someone who would give me a 2 out of 10. And the patient's like, well, I wasn't going to until you said that. So that's one. And two is you sort of lose the human piece of it. And so I think, you have to go into these things understanding that resources are tight, you're trying to make smart decisions, but there will always be that human element of it. And so that's sort of to me, the good and the bad side of all this data that we're sitting on.
Again, one of the themes that is actually starting to emerge is that technology is not the be-all and end-all. So clearly, you have to use technology wisely. And in fact, in a lot of our institutions, you have patient population where they don't even have access to good technology. So the way to use technologies in those cases is actually use it in the places where you think there is ways that they're going to access it, and then free up resources where you can actually have the human element coming in and actually helping those interfaces there.
So in terms of data and technology, two things. One, we're trying to leverage technology so the report building is automated. So the humans spend time on interpreting and contextualizing. And I'm big on that word. I think you can tell. The other thing in predictive, we have a similar concept. So, left before treatment completed is pretty high for us because of our population. And we're working on trying to predict which patients would most likely, leave before treatment completed. We'll see how it goes. We'll see how creepy it is or not. Aaron, I'll let him know. The other thing we talked about is the story. And, the dark side of data, sometimes it can be, if it's not understood properly, especially by senior leadership, it can be misinterpreted, misused. And so here's an example, employee engagement scores. If an employee engagement score is high in a department or low in a department, does not reflect on the manager 100%. Because if you're not looking at the entire context, if a manager went in to clean up a department, their score may be low. If a manager is letting team members do whatever they want, their score may be high. But you can't just tie that into remuneration. So what we're doing is we built a small algorithm on turnover metrics, transfer out, when people are transferring out for the same wages or transferring out in a position which is not in line with their career path, and a few other metrics, just 6, so everyone knows what they are, and using them to tell the employee engagement story. On top of that, we're putting in the patient experience story and the physician story. And so we're able to see all the data on the story, and then that tells us the story, right? And you can't build it for the entire system, so we are focusing on 12 units, which we are calling the most impactful units, and fine-tuning this correlation. And we need to remember correlation does not necessarily mean causation, right? Like, it's not necessarily because these two are correlated, one causes the other.
It's a good point. So I want to end this data conversation on a high note, because predictive analytics is actually pretty good. So I've been studying population health for a little bit, and I find hospitals are increasingly using big data to actually go and serve the community. So one example that comes to my mind is a primary care institution called Primary One in Columbus, Ohio. They partner with Mid-Ohio Food Bank and try to understand, okay, who are those patients that come into their panel that requires good access to good food, and then they actually tie up that in a way that patients are actually getting good food. So again, from a standpoint of using patient data where they live, it sounds creepy, but it's actually pretty good in that way, that these people live in food deserts where you don't have access to good food. And that's the reason why their diabetes levels are high, their blood sugars are high, their blood pressures are high. So they actually then channel them to Mid-Ohio Food Bank in a way that they partner it. And the evidence shows that actually improves population outcomes, population benefits. We have about 6 minutes. I want to see if the audience have some questions for our panel. Go ahead.
I'm interested in the predictive analytics. So you mentioned somebody that looked like they were going to give you a 2 versus maybe somebody that was going to be an 8. And focus your time. You give guidelines to people, but most of the time a 2 is a 2 and you can't recover them in the time they've got. But sometimes that's not true. So just curious what your thoughts are on that.
Great question. So this is a pilot, because that's all we do in healthcare, so we're piloting this. So how we're using it is rounding. And so I am not, I went into this project with the understanding that I was not messing with any clinical care at all. This should not impact anything that you're doing. We're talking about, I've got 20 volunteers today, where should they go? You've got a leadership person that wants to go around on a patient, talk to a patient. And so the guidelines that we've produced on the unit that we're going to try this on is we've picked a few of the variables. So for us, back to Vishal's point, our key ones are around nurse communication. So all the 3 in the nursing domain are to us most important. And so we've built a set of questions, and we've tried to understand which patients are likely to need us to focus more on that. And the rounding questions that we've designed is we've said, every day you're going to get a list of the 20 patients that we believe with a confidence level of X are going to need that. and here are the questions that you should go in and target and talk about nursing and engage in a conversation. We've built the script around it, so they're actually, I use the word questions. They're not questions, it's a conversation. Here's the conversation you should have with this patient about how they feel about the nursing communication. And so we'll see how it goes. It'll be very interesting. We'll obviously do sort of the mapping back at the end, but real quick, just, the point of all of this is we cannot round on every patient every day with all the things that we need to do. And so what this is intended to be is, where is your time better spent, and how do you not annoy the patients who don't even want to have that conversation with you? So,
We actually do the very same thing, but we actually acknowledge. So we use the data to sort of acknowledge what they are or potentially going to complain about, if they're going to complain. So one example is in this qualitative feedback that we have with the NRC portal, we found, this is how specific you can get with all of this information, that there's this one unit in one of our hospitals where the patients are scoring 10, 8, 9, so there are promoters and there are passive patients. But if they were to give us, if they were to take an HCAP survey, they're more than likely not going to give us an always experience because they're uncomfortable. And so they're rating us high, but then they're saying, but, the mattress is bad. And one patient after another was saying, so it's like, that's awesome. We can't afford to change all the mattresses out right away, but we can put mattress pads on them that we can order. So, and I'm using this as an example, probably not the best, but we will actually talk to the staff and give them tips to say, we've been hearing that our mattresses are uncomfortable. How are you feeling today? Because the theory that we have is that if we acknowledge some of their complaints and they know that we know about it and that they know that we're doing something about it, then they say, wow, they really care. And then they're more likely going to score us, a little bit higher. So that's how we're using that information. But, I just want to add that back to hopefully ending it on a good note, is that all of this data that we get it is very useful, but it's only as useful as what we do about it. If we don't really do anything with this information, if we don't change something, and so we've been really focused on doing that, as many are, but where we take that a step further, and I know this is a buzzword these days, but we're really taking it back to the people who own the processes and include the patient in redesigning their workflow efficiencies. More often than not, it's because there's an inefficient process in their workflow that's not allowing them to give the care that that they want to give. And so that's where we go back with the data and we use it with the teams, and we bring patients in and say, help us to recreate this, help us to redesign it. And just to throw a plug, we have what we call an Experience Innovation Cafe, where we take all of this different information, these stories that we're getting with our data, and take folks from all of the different sites throughout New Jersey, because we're spread out from the north to the south, and we have the team members come in and the patients come in and just redesign the experience. And it's about a 6-hour day, and they do this together monthly. Yeah.
Great. Other questions for the panel? Let me ask you one more question again. I want to go back in terms of, if you were to go back and think about this journey of implementing technology, not just data, but technology in your organizations, what are some things that we should do as organizations? Because again, as you're thinking about implementation, it's an organization-wide change that involves providers and patients. So what are some things that you have seen through your experience that organizations should do in terms of implementation of those things?
So, if I might, one simple thing that we've just implemented last week is, response to the call bell is important to our patients. So, when a patient hits the call bell, it's recorded somewhere in your back of house. When someone answers the phone, that's also recorded somewhere in the back of the house. And when someone physically goes in and turns off the call bell, that's also recorded in the back of the house. So we are able to now build a dashboard. We haven't done it yet in terms of display, but right now we're only sharing with the leaders of the units. But the intention is similar to the casino business, is when I end my shift, I know what was the average for the shift. Response to the call bell was 58 seconds or whatever, and I know what mine is. It's not publicized, but I know what mine is, where I stand. So it's a simple manner, because most people in healthcare are driven. So it's amazing as to how much difference just sharing that information with the managers, and right now the managers are telling the staff we don't have the screens in the back. But that's
More visual would help a lot then.
it would.
Right.
And just using technology to give them the information.
Great.
One of the things that we do is we actually created a decision-making tool, and we made sure that that was aligned with our strategic focus for the organization. But in there, we have things that we go through before we bring a technology, and especially since you can have more than one vendor who has potentially the same solution. But we ask ourselves, is this something that's going to promote efficiency? Is this something that's going to impact the patient or the team member experience? Does it align with our strategic goals? So we ask all these questions before we even move to the next phase. So before we bring in any technology, there's a rigorous decision-making process that we go through.
Great.
That's what I was going to say as well, because there's so many vendors coming at us, right? I don't answer my phone in my office. I'm sorry, I just don't do it, because there are so many calling, and the bells and the whistles grab people, and they want to say, let's try that. And so keeping things in a place where we can make wise decisions about how we're spending our money is really important. And so you have to have a system in place where that is occurring, or you have one-offs all over the place. And that's not really helpful to our patients because it's not well supported. And people don't, and the other thing is people have to use these tools, right? So you can throw a tool at somebody or technology at somebody, but if you haven't trained the people to use it appropriately, if you haven't got their buy-in as to why you're utilizing it, you've just wasted your money again. So I think we have to be very, very thoughtful about why we're choosing something and pilot it. I know that's a joke, but it's true. And really make sure that it's working if we're going to bring it on board and make our people learn it and then make our patients use it.
Great. I know the numbers were popping at us saying that we're out of time. So thank you again. I really want to appreciate the time the panelists spent. Thank you so much. And we'll be around if you want to have follow-up questions with that. Thank you.